Good morning to all the participants. We are welcome to the first webinar in Spanish that is sponsored by the Newborn Toolkit.
That is the
360. That is the toolkit for the care of newborns by the Pan American Health Organization and by the Healthy Newborn Network, the platform of Save the Children that provides information on everything related to neonatal health. Today, the thing is to have a number of learning webinars on the application of these tools. There's a series searches a collaboration to a partnership to work with the newborns. It's a group formed by UNICEF and WHO for the care of small and sick children. Today, we have a privilege of having a group of colleagues of the region of Latin America and the Caribbean, and we are going to talk about the data for action for the quality and equity of neonatal care in Latin America and the Caribbean. No, not yet. Please go back. So, if you wish to see at the bottom of the slide, you may see the QR code where you can register and receive the updates of this group. The next one, please. No, not that one. All right. Well, I am your host today. I'm Dr. Goldie Mazia, and right now, and for several years, I've been the principal advisor for neonatal health of Save the Children. And in the past, I was in the Neonatal Alliance for Latin America and the Caribbean. You may have met me with that hat. And please send your questions as soon as we start with the Q&A session or through the presentation. Please write down your questions in the Q&A session of the web seminar. So the next slide, please. So today, again, we have interpretation in all the languages in the region. We have English, Portuguese, and Spanish. The seminar will take place in Spanish. And we announce the next event on September the 10th that is called Babies and Bugs, Innovations for Neonatal Health and Antibiotics. So, as you can see, we have quite a busy agenda, quite a broad agenda. We have 4 talks and a Q&A session, and we're going to start with the first talk on neonatal mortality in Latin America and the Caribbean, equity and data systems by Dr. Pablo Duran. The next slide, please. Dr. Pablo Duran is a colleague and has been a friend for many years. He's a regional advisor on perinatal health for PAHO WHO. And he's the coordinator of the Neonatal Alliance for Latin America and the Caribbean. Dr. Duran is a medical doctor. He has an MPH and a PhD, and he specialized in pediatrics at the Buenos Aires University and has a fellow in international nutrition and nutritional epidemiology at Cornell University in New York. So go ahead, Pablo, with your presentation. Welcome. Thank you. Thank you, Goldie. Good morning, good afternoon, everybody, all of the colleagues that are with us today. And of course, I want to thank Ms. 360 for the leadership and the coordination of this seminar and the entire series. The next slide, please. So, as you have in the agenda, I'm going to talk about neonatal mortality in Latin America and the Caribbean. And essentially, I'm going to analyze and emphasize the significance that equity and the data systems have as a response. They are a key part in the approach of neonatal health today in the region of the Americas. The next one, please. Neonatal mortality. And this is something that everybody knows and is shared by the countries, both in the region of the Americas and the other regions. Neonatal mortality accounts for over 50% of the deaths in children under 5 years. And we know that the complications of prematurity, childbirth events are a significant contributor to mortality, but also to the burden of disease. The next slide, please. So in that respect, of the 15 million births that are recorded in the region of the Americas with a mortality ratio of 7 live births, we know that in Latin America there are 10 of those births with a higher rate of 9.3 over 1,000 live births, and with an absolute number of neonatal deaths that are over 200,000 deaths. And this is the first element that highlights the importance of continuing to work on perinatal mortality, but also the birth of preterm babies that will have adverse conditions in the future. In that regard, we know that there are national and regional frameworks that have guided the action of governments, the medical teams, and managers. And to be highlighted is the approval that in the region of the Americas, they passed the regional and global framework strategy that guided the approach of the care of newborns in the continuum of care of women, newborns, and children. And the implementation was continued until 2016. However, we also want to highlight the approval of every newborn action plan, the plan of action for each newborn, that made it possible for the region of the Americas to continue with this action and to promote and strengthen the approach of neonatal health. The next one, please. However, the situation of health in the Americas at the time that the action plan was approved for women, children, and adolescents in 2018, also approaching the positions both of the global action plan for each newborn, as well as the global strategy for women, children, and adolescent highlights. On the one hand, the lack of equitable access to health services of high quality for those populations, those care systematic action in terms of the promotion of health, the lack of systematic participation of people, and people-oriented approach. And I especially want to highlight, because this has to do with our seminar, the lack of strategic information to oversee the health status and the inequalities that that are a priority if we are to respond to the challenges that the region must address. So in that regard, the lines of action in this action plan, in addition to strengthening the political environment and promoting health and expanding the equitable access to care, is the fourth line of action is to improve the availability and the quality of strategic data for women, children, and adolescents. So it is unavoidable that we need to strengthen the data systems, and the data systems must provide data that may enable us to determine the inequality so that we can reduce its effect. The situation of health in the region poses significant problems, but in addition, they are sustained in time and they are preventable. The inequalities translated into inequalities are strongly present very often they don't have a good visibility in terms of the policies for the newborns, the families, and community, and they require the participation of a number of actors, thematic areas, and domains in the ministries of health. So in that regard, recently we published an article where we analyzed the neonatal mortality in the countries of the region going from 2000 to 2020. The next one, please. And clearly we see that in 5-year periods going from 2000 to 2004 up to 2020, how the gaps, the inequalities expressed by this box chart show us that there's a progressive reduction of inequalities among the countries. That is, the neonatal mortality rate in 33 countries selected has been reduced, and there are not so many variations from one country to the other. However, if we see the next slide, we can see that although between the year 2000 and 2004, the inequality, the gap was reduced in terms of neonatal mortality by quintiles of the Sustainable Development Index per countries, which means that to the extent that the countries with a lower Sustainable Development Index have higher neonatal mortality rates than the countries with higher Sustainable Development indices with a better economic situations. The inequality between the countries was only reduced from the year 2000 to 2004 and 2005 and 2009. However, what we see is that starting in 2005, there's a sort of stagnation, and we have not managed to reduce the neonatal mortality, especially in the countries with lesser Sustainable Development Index. So this shows that there's a delay, especially among populations that are in worse social and economic conditions. So we see, as we said, that there's a reduction both of neonatal mortality in the absolute and relative gap in the different measurements of inequality of neonatal mortality, but essentially the percentage of change and the annual average reduction of neonatal mortality and the absolute and relative gaps of inequality have only been substantially reduced between the year 2000 and 2004, but not so in later years. So there is a significant debt, and for that, we need to reduce this. So the neonatal, the system that gives us the possibility of collecting and analyzing data is not only for healthy newborns, but also premature, small, and sick that require care, as well as in the postnatal monitoring. And there are other cases, such as sepsis, that contribute in that respect. So this perinatal system provides automated reports in terms of perinatal results, as well as in the analysis of inequalities. And the countries adopt them and use them. And this is what we expect to hear and as we listen to the experiences in the region. So from the Pan American Health Organization and the Neonatal Alliance for Latin America and the Caribbean, we are committed to continue in the same path, providing tools that may contribute to surveillance, monitoring, but with a focus centered in persons and the reduction of inequalities. Thank you. Thank you, Dr. Duran. And now let's go to the second talk by Dr. Patricia Fernandez, who will talk about SIP overall, monitoring the small and sick newborn from discharge to the age of 5 years. Dr. Patricia Fernandez is the coordinator of the area of neonatology of the Directorate of Perinatal and Children's Health in the Ministry of Health of Argentina. Dr. Fernandez, you can start, please. The next one.
Good afternoon. Thank you for inviting me. It's an honor to participate. I'm going to tell you why data are so important in health and why. As we know, WHO recommends focusing care in the neonatal period to eliminate preventable mortality and providing quality care. And for this, it's essential to know the conditions of higher probability of occurring in this population to monitor them systematically, detect them early on. And for this, we need good data recording to identify patterns and trends and areas to work. So why are data so important? Because the appropriate analysis will help us, among others, to some of these. Maybe each of you could help me, but to improve care continuously, identify risk factors, monitoring child care in the long term, to classify health decisions that are evidence-based, to facilitate research, and something important, compare outcomes at national and international level. The Perinatal Information System in Argentina was consolidated as the data source to systematize health information and maternal and neonatal health. SIP enables us to easily have the most relevant information available and structure it in specific dimensions of interest to the health team, allowing a comparison between different health services. SIP Plus, as you may see, is the online version that is so important and that we're beginning to use in our country. At present, half of our jurisdictions, we have 24 provinces in our country, well, half are using it with excellent coverage, and neonatal SIP that we have been using for some time, but with 50% coverage is being updated at present. And we will have the SIP follow-up that is being strengthened. They are both being used. We thank PAHO for all the help to do so. Next, please. This is just to show you the coverage of the perinatal SIP in time. Starting in 2012, we have some ups and downs, but it's always above 70%. And starting in 2012, we have this package with a series of indicators for action. Next, please. Just to show you some of the indicators we may obtain with SIP. What we have here is information along the different axes and dimensions, such as quality of care indicators of mother and neonatal impact will be compared with the effector in time or with other effectors or jurisdictions in the country and at international level. Next, please. By way of example, to know how an indicator is built with the SIP data, let's find the variables we want to have an operational definition. That is how we build the indicator and its use. For example, below we have the prematurity rate. The variable is gestational age on delivery. The definition is prematurity rate, the number of newborn with less than 37 weeks. Next, please. Just to show you some of the many graphs we can obtain with SIP. This is a course of cesarean section in Argentina to take the necessary actions. I will now focus on high-risk newborn information, particularly after discharge. We all know the clinical practice guideline that is evidence-based with a follow-up of high-risk newborns in PAHO. It can be developed to provide recommendations that are evidence-based for follow-up of newborns with special conditions, to provide specific care that is systematized to conditions that we see early on. The target population are post-discharge high-risk newborns up to 2 years with a gestational age corrected in preterm babies, and it's addressed to healthcare professionals. This just to show you that we have this in the guide. We have the process and outcome indicators for their implementation. And the green one is a PAHO guideline published in 2018. And thanks to PAHO's support in Argentina, we could adapt it to the local reality. The format is similar, and there are differences, particularly up to 7 years, because we follow the high risk babies up to that age. The follow-up is done by different experts in the country, in the neonatology area, and with the National Quality Directorate. And this was adopted at ministerial level, incorporating it into the National Program for Quality Care in 2023. This just to show you the checklist we have in our guide. Here we take the different variables in order to, next please, in order to the follow-up. It has a similar format as the SIP and the neonatal SIP. It starts on discharge at 40 weeks. It's very small type, but it doesn't matter. You don't need to see the variables. I'll tell you later. Next, up to, as you will see, up to 7 years of age, not 5. 7 years then. Next, please. Some data we gather in the neonatal SIP and the monitoring SIP, demographic data, gestation age, weight at birth, sex, clinical data, diagnosis, treatment, and complications, medium and long-term follow-up data, growth, neural development, neurosensorial development, early detection of complications, if there's access to diagnosis and treatment, and special care, healthcare needs, if they have been readmitted and more common causes, and if there are associated disabilities in certain cases and diagnoses. This by way of example. Also, some indicators we may obtain with the SIP-NEO. Next. Apparently, there is something in the screen that doesn't allow her to see, but now she's corrected it. Follow-up or monitoring SIP, some indicators as proposed, it's ongoing. And by way of example, at present with SIP-NEO, we now have and we will have with follow-up one survival indicators, population data, morbidity, growth, breastfeeding, duration of hospital stay, the tests being done, neuroconduct development in the long term, if it was timely diagnosis and treatment with indicators and rates to know the strategies and actions that will be taken. Of course, in spite of all the benefits, we know this has the implementation of all the registration systems have many obstacles. And I return to what we said before. You may say we have more or less, but the lack of resources, be then the human or technological resistance to change in this regard, maybe elsewhere use different databases, and they must be interoperative with safe lack of training, logistical difficulties, and of course, the budget available. Next. That's last. Next steps in our case to completely update our SIP-NIL and monitoring SIP to do the training in all jurisdictions to continuously accompany the factors that require it, and of course the use of information for action to prevent disabilities linked to prematurity or any other condition neonatal children have, to organize risk surveillance, articulating levels of care, parenting, timely interventions focused in the family and community, and manage access to special healthcare needs. Thank you. I'm open to questions. Thank you, Dr. Fernandez, and also for sticking to the time allocated. We will now hear the third presentations, registry systems to monitor sepsis and infections linked to newborn health care by Dr. Sinovia Quispe. Next, please. She is an officer in the National Epidemiological Prevention Center and Disease Control. If you remind me, Dr. Quispe? Peru. Please. Next. Thank you. Good morning. Thank you for inviting me to participate in this seminar that is so important to add efforts for neonatal health. In Peru, we've been working in healthcare associated infections since 2005. This is our last standard, 2020. We've been adopted it in 2020 to standardize the methodology to gather data in different cases. Healthcare-associated infections as an adverse event have been specifically defined. It's a local systemic condition resulting from an adverse event, the presence of an infectious agent or their toxin that may occur in an ambulatory or hospitalized patient. We consider healthcare-related infections when we're sure this didn't occur on admission or readmission. Our surveillance system has certain specific features defining it, the manner how to select, that is to focus our efforts on devices with a high risk of infection, particularly medical invasive devices. It's focused on critical departments. It's active surveillance because there is this intention by the health staff to search, to classify these cases, and it's constant because it requires being sustained in time. The surveillance network in Peru includes the local level in public and private facilities. It's universal and mandatory in the country. It's at intermediate level in the regional directorates and in the CDC. Next, please. Our surveillance networks to date has included over 500 facilities. Of these, have 96 hospitals and institutes that work with neonatology, particularly ICU care. Additionally, the neonatal, apart from the neonatal ambit, we have other departments in newborns doing surveillance for infections in the bloodstream, for example, and pneumonia, surveillance requires that the health facility have a surveillance plan establishing the events to be surveyed and reporting when there are other procedures. Gather data according to the standard methodology, analyze, interpret, and disseminate them in the department.
So there must be somebody in charge of surveillance. Ideally, it should be a skilled healthcare professional. Mostly they are nurses that collect the data efficiently, and they need to have access to the data of the medical record, consolidating the data, analyzing and reporting them, depending on the circumstances. The standard establishes that you need to have a standard of 1 per 100 beds given programmed in the IPRESS. So that is the availability that we need to have in order to be able to monitor the case as well. The case definition for the bloodstream infection are based on the WHO criteria, and both for the bloodstream infections. In this case, they are related. I'm sorry, but could you speak a little louder, please? The colleagues tell us that they can't hear you well. Can you hear me now? Can you? Yes, that's better. Thank you. So I was saying that the case definitions are updated based on the CDCs and the WHO. And so here we have a bacteremic confirmed by the lab as clinical sepsis, but there are also healthcare centers with a low capacity for cultures, for blood culture. So we use the case definition based on the clinical aspects. So for mechanic ventilation associated pneumonia, we use clinical and radiologic criteria, and also case definitions that may include cultures, blood cultures, depending on the what is required by each case. We've now we have a web app that summarizes data. Is you register for the first the patient for the first time as is admitted to the hospital, and it provides general data that allow you to identify the patient. And then in the lower part, you can see the main medical devices that the patients are exposed to, using our symbols so that the app may count the days of exposure to the devices. I'd like to mention that the registry of cases of patients, it's only necessary to complete additional data when these are other new infections. Data related to infection, risk factors, and with the sensitivity profile of the potential culprits of infection. Now we have the problem of antimicrobial resistance. So we have two apps. We have the IAAS web app and another one that records the outbreaks and other health emergencies. In the case of the web app, we have the surveillance of medical devices and neonatology, such as central catheters, the peripheral vein catheters, and the mechanic ventilators, parental nutrition, and the surveillance of and the monitoring of the neonates based on their weight group. we've had advantages of this app, and that is that it has enabled us to improve our data registry to optimize the quality control of the data, the timeliness of reporting, and to avoid inconsistencies in the data. However, we've also had limitations, and this is the availability of the staff, the internet connection, because you need a good broadband, but we are seeing the possibility of having an offline app, and also some circumstance, in some cases, the lack of operational IT teams. The reporting is done once the month is completed within 7 days, and it requires a username and password. The results of epidemiologic surveillance have enabled us to monitor and to establish baselines for infections, as well as providing significant data to improve practices and services. And at a national level, we also have benchmark indicators of IAAS. We publish an epidemiologic newsletter. And here we have the neonatal, we record the bloodstream infections, those associated to peripheral lines, pneumonias, associated to mechanical ventilation, and we have the number of days of exposure for each of these infections. And in the outbreaks, this allows us to provide to design contention measures. The epidemiologic alerts are precisely related to the new findings of resistant organisms, as reported in the surveillance, and this has enabled the country to position the IAAS as a performance indicator that is monitored in the cohort periods. These are required to post, at least to prioritize the highest rates, the 2 highest rates, and based on that, we can evaluate the progress annually. The next one. And this year, we had an opportunity, that is, the Congress will approve the Law 31/972, establishing the strengthening of surveillance, prevention, and control of infections, as well as the accreditation of centers for the control of infections. Finally, IAAS is a latent problem that includes, that goes beyond the hospitals. These infections require training of human resources in infection control, and the existence of the other programs combating sepsis and resistance. The registries are a very important tool, but they're also a challenge to be updated. However, as a country, the experience is that surveillance of these infections is the cornerstone for decision-making in prevention and control. So thank you. This is our team. Thank you, Doctor, for your very interesting presentation, and also for keeping your time. Exactly. And now, the advances of Nicaragua, the registry system for monitoring the response to sepsis, and the advances of Nicaragua in the Perinatal Information System. Dr. Maria Auxilia Gadea is the coordinator of the comprehensive care of childhood of the Ministry of Health in Nicaragua. So you have the floor, Doctor. Good morning, good afternoon, all of us. It's good to be getting together to discuss the Perinatal Information System. As to our background, we have a long history. Since 1990, we adopted in the country. We have had ups and downs. However, starting in 2019, in 2014, we started with 2 hospitals, and from there, we made a third change in the perinatal clinical record, and we worked with all the electronic data. The most important thing is the political will of a good government that gives us many advantages to all of us. So we have developed standards, and at present, we have included those in the platform. This means that this program is here to stay, and it will go on further. So the next one, the Perinatal Information System. We already have 3 modules. SIP abortion. We are monitoring the SIP abnormalities, and the neonatal SIP, as was mentioned by some of the previous colleagues. We have a regulatory framework. 078 is the standard it shows what we can do with the system, how we can work this. All this is stated in the regulations, both for registration and for the registry and for our outcomes, the results that we can obtain for decision making. We also have the instructions of the modules, the instructions for abortion, neonatal and congenital abnormalities, and we developed 2 atlas, one of neonatal defects that is to your right at the corner, and an atlas on congenital natal abnormalities. So this regulatory framework this allows us to check everything that we have in the system, and this includes all the information, and all this is included in the system, and we also have it in a publication in our platform on the website of the Ministry of Health. We have a robust backup for the implementation of the Perinatal Information System. As to the prenatal and postnatal abnormalities, I liked it when you chose this topic, because if we see the neonatal mortality, the main problem is in congenital abnormalities, and the second is prematurity, and third, sepsis. So congenital abnormalities are a health problem. So we need to monitor that. So we have a very good team, and we have it integrated. There are 28 doctors, 18 perinatologists that are in the regional centers and the national and department hospitals. We have the maternal and fetal doctors in the regional hospitals, and in the hospital Berta Calderon, and we have a fetal surgeon that gives us support, and he is the one who launched all the surgery intrauterus. So how do we do? Through the perinatal clinical record, we adapted it based on our needs. In the upper part, in the circle there, we show that the antenatal abnormalities, and then you have the other circle showing the postnatal abnormalities or congenital abnormalities. And later on, well, it may have been detected antenatally, however, it was not surgical, and therefore the child was born with that congenital abnormality that is going to be treated further on. So we have the record for congenital abnormalities. This upper part is where we describe the antenatal abnormality that was found, and there you have a description of the congenital abnormalities. And here we have the abnormalities, and here we have especially the prenatal abnormalities, because these patients, thanks to the timely detection, allows us to describe here in this space what kind of abnormality the baby has, so that our staff, our doctors, may monitor the baby properly.
Plus is a family and community health model that has provided excellent results because it's in the community and it's focused on the pregnant woman who is recruited before 12 weeks. Right now, we have nearly 80% of early detection. We fill the history in the Perinatal Information System. In the country, we have 2,700 sectors with 2,400 family and community teams of tablets, so that there they have the SIP, primary health care, to register these pregnant women, so that at any time, be it with an abortion or preterm delivery or whatever, they go to hospital. So they are examined there to have all the antenatal information at the time of providing care, be it in hospital or wherever. How do we recruit these women? We do comprehensive screening in the first trimester, and we have a timely detection of antenatal effects. They can be recruited in primary care. If we detect an antenatal abnormality, we refer them to perinatology, to the perinatologists we have in every department or in regional hospitals. They are assessed by the perinatologist and then referred at national level. At this level, they are reassessed, and there we determine if they require fetal surgery. Immediately after 24 hours, this can be conducted. If this is not necessary, then we refer them back to the region for follow-up by the perinatologist, and if necessary, at national level by the fetal surgeon. That is then how the flowchart works for antenatal abnormalities. As for monitoring of coverage of national tracking indicators, we have coverage under 70% that's spread, 60% to 80% that's half and half, and high coverage 80-100. As for coverage of the clinical records, in 2023 we had 69% coverage with the perinatal record, and in the first week of 2024 we had 67%, meaning that of every 100 pregnant women who have had a delivery, 67 have been recorded. This is useful so that we can have more reliable information, to know the conditions of care to improve it. As to this 100%, given the follow-up we have had in congenital abnormalities, we have a 100% coverage in 2023 in women with antenatal fetal abnormalities, and in 2024, 83%. Next, please. What have been our success factors? First, we have the political will. If that were not present, we couldn't conduct it. But as you may see, we have had many years in this process of forming a community health model that enables us to have this timely outreach to pregnant women early on in their pregnancy. It's free of charge. It starts in the first level of care, not only at hospital. The maternal and fetal team has been strengthened with all this medical staff, as mentioned, strengthening of healthcare staff capacities at both levels, and with the heads of the department involved. We have a commission, including all these people, both in primary health care and at hospital level and secondary care. Systematic monitoring visits have been one of the great successes to improve coverage, both at municipal level with low coverage, with the track indicators, both pregnant women, abortions, defects, and needs admitted to the neonatal ICU. And we're currently working on missing data, and something that we have taken into account and follow up in this monitoring regards information according to variables. And we stress this, for example, if their data are incomplete, the report will be incomplete. So we really use the variable information data. Excuse me, we are on time. 2 slides more, please. No, this is the last. Advantages of using SIP Plus, as we're aware. This is a management tool to monitor the population with the real information. It's evidence-based. It favors compliance with standards. We assess and monitor 26 standards, and it facilitates communication between both levels of care, primary care and hospital care. Next, please. Next steps. We will implement new modules, violence, family planning, and adolescence. We're working to adapt SIP to ICD 11. We want to have interoperability with the e-record. This is ongoing. And continue training the healthcare staff with the systematic monitoring of track indicators. Thank you. Thank you, Dr. Garcia, for your most interesting presentation, and all speakers. Right now, we have time, not much, to evacuate any questions or receive comments. If we don't have time enough to answer all questions, we'll ask the speakers to do so in the Q&A window, but I'll take a couple of minutes. Well, we have a question for Dr. Fernandez. It's from Patricia Barrios. If you're suggesting in the country the kangaroo mother care method as a process indicator, kangaroo mother care for preterm babies and low-weight babies, this has been done in Chaco. Thank you for the question, Dr. Barrios. What we use in our country, and this is, well, it's not kangaroo mother care, but the skin-to-skin method, and it is one of our indicators. As I said in my presentation, there are indicators that are automatic and others that we may include as desired with SIP neo and SIP follow-up data. Thank you, Dr. Fernandez. We have a comment. Unfortunately, it's anonymous. about SIP in Honduras that is only installed in hospitals and not in primary health care centers? I can't see any further questions right now. I have been asked to see the next slides. Next, please. Thank you. You may send questions until we close. So we're going to ask the speakers to answer if they come up. We recommend that you form part of the newborn toolkit community for neonatal care. Remember, we have coming events on the 10th September, as mentioned, on neonatal sepsis and antimicrobial resistance. Next, please. People ask about the recording. Yes, we will have it available starting tomorrow. No, she corrects herself. Next Tuesday, it takes a week. And the last announcement now about the newborn toolkit. On August 27th, we'll have a contest for essays. It opens in August, and in October, we will announce the winners at the special website seminar and the World Newborn Day on the 27th November. You may win £500 and a certificate in a publication in the Journal of African Neonatology with a chance to increase your networking and participate in the Neonatology Conference 2025 and have a participation in the podcast for Global Newborn Incubator Network. So please, you can take a look in the Newborn Toolkit website. Next, please. Once again, thank you for being with us today. We thank Dr. Joy Long also for having organized this webinar in Spanish, the first in this series, to the colleagues in the Healthy Newborn Network, PAHO, indeed, for organizing and having made presentations. So please subscribe to the different updates in all languages, as you may see in the QR code, both in English, French, and Spanish. Thank you all. Are there any last comments? Joy, maybe, or anybody else?
Well, I apologize, I don't have Spanish, but I really want to thank all the team. We learned so much from Latin America. Thank you, Goldie, for advocating for this, and Pablo for your leadership, and all of you have learned so much, but unfortunately not learned a lot of Spanish yet. But we have to do this again, and we really, really appreciate. Muchas gracias.
Dr. John says she's sorry she doesn't speak Spanish, but she's very grateful for having hosted this webinar. She thanks all the speakers. Well, let's continue. Thank you all. See you next time. Bye.